to the webinar. Today's topic is substance abuse and seniors. Will be a general overview of substance abuse in older adults, and it will include a nursing home case study involving a nursing home resident. This is Mercedes Byrne-Klug speaking to you as your host from the National Nursing Home Social Work Network. Welcome. Our co-host, Bob Conley, will be joining us at the end of the session with a question, perhaps. So you might be hearing from him later. And I welcome you from the University of Iowa, National Nursing Home Social Work Network. Today, substance abuse and seniors will be presented by Lori Nisson. She's a social worker. She's, in fact, a licensed independent clinical social worker, and she's spent over 20 years specializing in working in gerontology and in older adults, especially older adults experiencing emotional, cognitive, and behavioral problems. She's a presenter and an educator and a trainer, and she provides information to professionals and to caregivers on topics related to older adults, mental health, memory changes, mood disorders, and behavioral issues. She's with the Behavioral Health Specialists group, and her contact information is also at the end of this PowerPoint. Lori's going to speak for about 45 minutes, and then we'll open it up to questions. If you have any questions before that, go ahead and put them in the Q&A box, and I will see if they are, and we'll go from there. So I'm going to turn it over to Lori now. Thanks, Lori.
Thanks, everybody. If you're a familiar background noise, you'll notice that I'm also in a nursing home right now. So the background noise of beeping and doors opening and closing will be very familiar to all of you, I would imagine. So here today to talk a little bit about substance abuse problems in older adults, and I think we've made just a little bit of headway in raising some awareness, although I think there still is a lot of stigma around substance abuse, and particularly around older people and, you know, societal and healthcare and community people really having a harder time accepting that this is a recognizable and significant problem. So you can see some of the statistics here. We say that 1 in 6 or 1 in 5, depending on the literature that you look at, has a problem with alcohol. With older people, we have a lot of healthcare diagnoses and outcomes that are related to substance abuse, both liver issues as well as memory disorders. And we estimate that about 70% of all hospitalized older adults and up to about 50% of residential older adults may have an alcohol-related problem. We see that as people age over 65, particularly people who are widowed, often turn to alcohol as a means of kind of coping with loneliness and some of the life changes that we're going to explore. We say that people who are widowers have a higher rate of alcoholism, often because they live alone and are more isolated. And enough, in the area I serve, in fact, I'm in Sun City West right now, Arizona, there was a statistic that came out from our governor's office quite a while ago, but is still valid, that we had a high rate of exposure on alcohol of any city in the United States. If you're not familiar with Sun City, it's the first city that was developed as a Del Webb senior-specific community. So just about everybody in the city is a senior. Most of our seniors here are, buy alcohol, not so much in a bar, but really in kind of the regular places like drugstores and grocery stores. That there's a high rate of use of opiates, sedatives, narcotics in the older adult population. And what we're seeing in the addiction field, and you're probably hearing a lot in the news, both of adults and older adults, is that often people are prescribed these medications for a legitimate problem. they have a legitimate pain issue or sleep problem or something that precipitates the prescription of these medications. But what happens is that people over time develop a habit or dependence. Alcohol abuse and drugs is, a serious health problem in our society, and both in teenagers as well as adults and older adults. And we have a higher rate. I saw this recently on the news. Arizona in particular has the highest rate of prescription medication abuse. So we see that probably watching television, hearing about the NFL and other sports industries and other community issues, we're hearing more and more about the problems related to prescription drug abuse. We've seen it happen in some of our rockers and other people that, again, find someone to prescribe a medication for them. Maybe it was a legitimate reason, and then they develop a dependence on that drug and need more and more of it. And that are prescribed, anxiety medications, pain medications, and in particular sleep aids, really should be prescribed short term. But what we find is that people are taking these medications for an extended period of time. I've worked a lot of my career in psychiatric programs in patient hospitals, and I've seen people who have come on drugs like Xanax, for example, that was in for 80, and have seen people who've been taking that medication for 25 years or more. So an increased tolerance as well as that physiological dependence that occurs over time. Women are more proactive in seeking healthcare treatments and mental health care treatment than men, and they are prescribed psychoactive drugs than men are for that reason. And seeing, the older generation, but also seeing our baby boomers aging. We're seeing more illicit drug use. We used to talk about substance abuse and older people exclusively related to alcohol, and then we started seeing a rise in the prescription medications. As newer and better and faster medications came out, we saw a rise in that use, and now we're seeing more illicit drug use as we have baby boomers and populations who are more exposed to drugs like cocaine or marijuana or even methamphetamine becoming a problem in the generation that's now becoming seniors. Too, where grandparents who are living with grandchildren or their children for economic reasons and see how substance abuse issues can affect them very directly. Either they're starting to use the medication, or often they are covering or masking or enabling the problem in the population below them. Are the signs and symptoms that we see. And as you take a look, you'll notice that some of these signs and symptoms mimic other things that we are concerned about in aging, like depression, dementia. We see someone who particularly is living at home alone. We're seeing people who are more accused, having falls, but the population we're seeing in the nursing home, we are also seeing people who are losing weight when we're taking pain medications, for example. The side effects of the medications is they can increase constipation, they can decrease appetite, and seeing some of the signs and symptoms that you see on your screen here with weight, hydration, sleep disturbance, and the others that I've already mentioned. So some of the symptoms that we might see in someone who is abusing alcohol would be a flush face, be nausea, trembling, incontinence and headaches, and blackouts with extended use, and an increased tolerance. One of my early jobs as a social worker was in a more rural community, and it was a substance abuse specific assessment that we do as we went into people's homes. And what we would see is that people who were in more rural areas were more isolated, spending more of their time using alcohol to kind of cope with some of the life changes. And so some of the other signs and symptoms that we would see in this population were people who were really deteriorating, decreased hygiene, decreased nutrition, people who were drinking their lunch but not really eating much nutrients. Really a general self-neglect. An older adult population, you're kind of hard-pressed to see somebody who has a substance abuse-related problem without the comorbid issues of anxiety or depressed mood, maybe someone who has an extended period of grief, and that comes more of those psychiatric symptoms, the suicide thoughts, thinking life isn't worth living, and with more extreme abuse of alcohol, medications, or drugs, we're seeing the results of aggressive behavior, maybe verbally abusive behavior, and we also see a lot of signs and symptoms related to their psychosocial status. Maybe they have family problems, maybe they're having financial problems, they're overlooking their bills, they're not taking care of the home. I would pull up into these homes to do an assessment in the substance-related program that I mentioned. You might see someone who is living at home by themselves. We've got newspapers piled up outside. Once you approach the home, you can see that things are really starting to be neglected inside. Accompanied by substance abuse, there's particularly older people. We don't see a lot of group drinking or partying. More often than not, we're seeing that social isolation. People who are really withdrawing from friends and family and becoming isolated. I see legal problems in the older adult population, people who are getting into automobile accidents or tickets related to their alcohol or drug use. People who are attending events where drinking is accepted, and we do see that even in long-term care assisted living settings where happy hour occurs. But more often than not, in this population, you're really seeing somebody who is drinking or abusing their medications in a more solitary, hidden way. Really that anhedonia that accompanies, where they lose interest in activities and things that used to be pleasurable and are drinking despite the warnings that they have on their medications, or feeling increased anxiety or depression and taking a lot more of their medications to feel the same effect. In my in-home assessments, I remember seeing a lady who kind of fits this slide. She had been discharged from the psychiatric hospital and had not followed up with her outpatient treatment related to or prescribed for her depression and substance abuse. And when I came to her apartment, often we see someone who was intoxicated or tipsy, but in she seemed, she seemed calm. She didn't appear intoxicated. But I see out of the corner of my eye, she had one of those very large bottles of, Ern Julio Gallo, one of those jugs of wine, and I could see that it was almost empty. And as she asked me to sit down, I could see that she was heading the other direction. And when I looked again, that bottle had disappeared. Kind of hiding and secrecy that we see, particularly with substance abuse, because what we see often in substance abuse is that that inability to really accept that this has become a problem, but to try to hide this problem from people around them. Live by themselves, it may be that they're drinking and having some bruises or burns, particularly if they're living alone. We don't see many people smoking, but when I was doing this, 20 years, we would often see people who had their little chair, they had their recliner, they had their glass with what looked like water, but might be vodka or gin, had their cigarettes set up and their remote control for their television, and they called it nesting. That was really where they kind of sat and spent most of their days and evenings. Other signs that you might see is mood, irritability, depression. Someone who's really having trouble keeping up with routine chores, paperwork. And in extreme cases where the dependency has really become more physiological and increased over time, we're seeing people who maybe even have irrational fears. They see under unusual stress, losing their memory, their confusion as added. And that's really difficult to tease out. If you're someone who is abusing medications or drinking alcohol, we quickly label them as having dementia, but what neuroscientists often say that 4 or 5 months of someone being sober or clean, we would really need to better test their memory, because it may be that some of that memory will come back if they stop using the alcohol or the drugs. So older adults as kind of fitting into a couple different categories when we look at substance abuse and substance dependence. So we talk about early versus late onset. So survivors are a group we talk about, and those are people really who've had an addiction throughout their lives. And that's the majority of the older adult substance abuse population. These are people who've had a long time problem with alcohol or other medication. And then they have a lot of the medical problems to prove it. Cirrhosis liver, and often they're developing a legitimate dementia because they've had so much abuse and it's affected their brain over time. A third of this group are really intermittent drinkers who binge drink, but the majority of them are really people who have just long pattern of destructive behavior. And these folks have a history of problems. They have legal problems, DUIs. Maybe they were asked to retire early. And maybe they've had so much recidivism with their disease where family members have gotten them into treatment or tried to get them into treatment, and they've either succeeded or failed, or maybe succeeded for a period of time and then went back to the alcohol or drugs. And so often our family members who have just said, you know what, Lori, I want to be supportive, but I've had to set these clear boundaries with this person because it just can't be part of their life. I can't watch them self-destruct. Maybe they've become, verbally or physically abusive to children as a result of alcohol or drug abuse. And so often they are very isolated and lonely as family members have given up on them. This is the second group of substance abusers who are of the older adult population. And these are people who typically have a long history of alcohol or drug abuse, a smaller population, about a third of the group that we're talking about. But they really began abusing alcohol or drugs later in life, and it was really secondary to a trigger or a stressor. They're typically a group that doesn't have those long-standing severe medical problems because the problem has a later onset. Where men tend to fall into more of that survivors group of people who have a longer history of substance abuse, women fall into this group of the reactors, people who start drinking or using drugs later in life to cope with some psychosocial stressors that we'll talk about a little bit later. Things like retirement or loss of a spouse. So statistically, single women drink more than their married counterparts and are secondary to the stress and loss, increases the abundance as people age. The good news about people who start drinking later in life is that they tend to be more responsive and have more success with treatment. So what psychosocial risk factors that would make someone at higher risk for substance abuse? These risk factors would apply even to other mental health disorders like anxiety or depression. So when we think about retirement, children leaving home, what we see out here in the Southwest are people who moved out to Arizona because they thought they would have a better quality of life. Things would be less stressful, the weather would be better. But what happens is they leave their entire support system wherever they came from, New York or the Midwest, and they realize that their trouble, changes without the support system that they had once before. We all see external losses, and any of us might experience an external loss. The most obvious one is the death of a spouse or friends. But as people age and they're getting older, the losses pile up. So, you might have the loss of your friend and also your neighbor, and your brother just passed away, and your husband's on hospice. So those losses really pile up, and it makes it really difficult for people to cope with those multiple losses at one time. About retirement, be the golden years, but we've seen a lot, especially with the economic downturn and with people retiring and living so much longer than they anticipated, that finances become a real stressor for people. We touch traffic relocation and marital stress. I do some counseling with older adults, but also with couples. And it's really interesting, as people retire, the couple have much time together. Once they're spending a lot of time together, it can create a lot of marital stress. Losses we see are more physiological. We know that as people age, they have more physical problems. They have more sensory deprivation, hearing loss and vision loss. And all of those things affect their ability to enjoy the things that they normally have, like reading or participating in groups. When you have a hearing loss, it's really stigmatizing. It really makes participating in social situations much more difficult. We also see people who have the physiological, like arthritis, osteoporosis, and pain-related issues, changes in mobility, changes in ambulation. And again, that affects people's quality of life, as maybe they're to golf and now can't golf because they are having these physiological changes that are really impairing or interfering with their ability to enjoy and find things pleasurable. And deficits that we see. We talk about how we're seeing so much more dementia and memory impairment. Well, the primary reason is that your greatest risk factor is age, and people are living so much longer now that we're seeing a rise in cognitive deficits. Health issues, depression, anxiety, grief, people who are self-medicating to calm their nerves or soothe themselves or escape from some of these stressors that they're trying to cope with. For adults, we see changes in the way that they respond to alcohol and medication as opposed to younger people. So we see a lot of younger people who we talk about going out and partying, spending time in bars, they're very euphoric. But know that extended use of alcohol or prescription medications is really dysphoric. So it magnifies the feelings of loneliness and sadness that triggered that person to abuse alcohol or drugs in the first place. We know physiologically, as people age, physicians say, even in prescribing, start low, go slow. And that's because as people age, they're physiologically much more sensitive to alcohol, medications, even to anesthesia. Enzymes metabolize alcohol and medications less efficiently. And you can see from this slide, we're seeing all these physiological changes that make people much more sensitive to alcohol or medication. So someone at age 40 who has a couple of drinks might be able to metabolize and manage that alcohol fairly well, but someone who's in their 80s, much harder time. And 2 glasses of wine really feels more like 4 to their system. You throw on top of the fact that so many of those folks are taking a long list of medications. The risk for interactions can be very dangerous. Older people versus younger people, we established that older people tend to isolate and drink at home. They purchase their liquors in stores, not bars. The point is that they're less likely to have legal problems because they're often drinking at home and not driving. But on the other hand, that makes them more isolated, and it makes it much more difficult for us to identify the problem. This really unusual phenomenon here out in Arizona in these retirement communities where people don't just drive their cars, but they drive golf carts. And if a physician said to them, hey, it's really not a good idea for you to be driving any longer for whatever reason, maybe it's dementia, maybe it's macular degeneration, people think it's okay to continue driving their golf carts, which brings up other safety issues, of course. So in diagnosing folks who are having a substance abuse problem is that they may be retired, so they're not encountering those work-related problems. They may be less likely to be identified by the police. They're more isolated, which decreases the chances that someone will recognize the problem. And then we have ageism. And we hear this sometimes from family members, the idea that alcohol and medication problems are rare and we hear things like, well, she's just getting old and that's all she's got left. So we idea that we're just accepting that because older people are getting older, that they don't deserve the same quality of life as younger people. And we know as workers, as healthcare professionals, that that's wrong. But we often see that kind of ignorance in, family members, community members, or even healthcare professionals. I mean, I think we've gotten a lot better, but when I worked in geropsych, we would have someone who would end up in the emergency room because they had been drinking binge, a 2-year-old woman, and got labeled very quickly as having dementia without taking a blood alcohol level in the emergency room. Is a hallmark of substance abuse related to any population, younger or older. And it's really experienced more as a deep sense of shame and guilt. And again, that age-based prejudice doesn't help the situation at all. And the lack of knowledge of information about a diagnosis and being aware as a professional about the resources that are available for treatment for our population. We know is that teens and particularly older adults can be very sensitive to a detoxification. So we often will see people who really need to be medically supervised in a hospital setting. It may be if that person is in skilled nursing, they've developed a dependence on one of the prescription medications that mentioned that person could be medically supervised in a skilled nursing home to be detoxified right there, or it may be that they need to go to a psychiatric a psychiatric program for, detoxification. But what we talk is that it's a very short stay. And that person is really going to need some follow-up counseling, because if they've been using alcohol or medications to cope with problems, they're going to need new coping skills to be able to better manage those stressors. Alcohol-related dementia, we see that. I'm the clinical director of Dementia Behavioral Program, and one of our gentlemen here has Wernicke's-Korsakoff syndrome. He had an extended early onset of alcoholism and extended career and dementia as a result in his 60s, early 60s. So we know that there is an association between long-term alcohol intoxication and long-term prescription drug use and memory impairment. Alcohol or medications can really damage the brain, and that can be direct or indirect by causing malnutrition and a loss of important vitamins like thiamine. So, and substance abuse is thought to be uncommon, but really is more common than we thought. And alcohol-related dementia is thought to be the same, that it's really more underdiagnosed. Family system issues contribute to this problem. There's often denial or enabling behavior. We see in some situations where there are two spouses, they're both substance abusers, and one person doesn't want to get help and the other one does, and that situation doesn't tend to work very well. There may be some unresolved relationship issues with their adult children, as I mentioned, that can impede or affect their ability to into recovery. I think we think about the 12-step model, and we think about a very confrontational approach, but in my work I've found that with your adult population, building rapport first is a much better approach, not a judgmental approach, reinforcing that person's personal strengths and identifying the challenges that they may be facing, what stressors may be contributing to the problem, and what are their triggers. The goal is really to help people develop more effective coping skills, help them provide strength and support, developing assignments to help that person strengthen insight, commitment, and empowerment. I have a gentleman in our outpatient practice right now who is a young older adult in his late 50s and has had multiple back surgeries and developed a dependence on narcotics. And the wife had separated from him. That was kind of his bottom of wanting to seek help for himself. And so he really having to find new ways to cope with some of the marital stress that he faces, some of his physiological problems, some of his pain, and really learning new coping skills so that he doesn't go back to using these medications. And he was, pretty skilled in finding a lot of different physicians to prescribe different medications to help him get the level of the narcotics that he needed. We have emergency room trips, medications, and so I think people get very clever in finding ways to get the medication or the drugs that they feel they need. I did a consult on a woman years ago who was in a rural community, had real sensory deprivation, didn't hear very well, and was legally blind, lived alone in her own home, and had built a partnership with this caregiver who lived rent-free on the second floor of her home. And a friend of hers and really cared about this woman and was concerned about her increased alcohol use, but could not figure out for the life of her how this woman was getting her alcohol. It was a rural community, at least 15 miles to the closest quick or grocery store. The caregiver knew that she wasn't buying the alcohol, but this woman was finding a way to get her alcohol, and what she had done was enticed the landscaper to the alcohol for her by him, very gifts. So much people develop a dependence to alcohol or another substance become very clever and adept in finding ways to get the alcohol, the medication, or the drugs that they need. Just to touch a little bit upon group counseling. Groups are very effective in helping someone in their peer group that might consist of older adults can really foster validation, normalization, and acceptance. And confirmation from peers can often be more acceptable and more powerful than hearing that same information from a professional. One of the group counseling is that the group has to be somewhat homogeneous, because when we've referred older adults to mixed groups, sometimes that just validates their level of denial. So the example here, a 78-year-old alcohol abuser might not relate to an 18-year-old crack addict. I really just drink too much beer. He's the one who has a really serious problem. He's using illegal drugs. So we have to be careful about the groups that we set people in to make sure that they're going to be able to relate to people in the group and develop some camaraderie and respect and understanding. Be helpful in the group setting is that it can really develop social relationships and help that person develop more effective communication skills. There's an old saying in Alcoholics Anonymous, you've got to change your playground. So if you were spending a lot of your time in bars or spending a lot of your time finding creative ways to get to the emergency room to get prescribed pain medication, to find new social relationships, new coping skills, and help your people to hang around. Anonymous has been around for a very long time, and sometimes I'll refer family members who are really struggling with the idea that they want the person to get help, but they've seen that their own behavior may be contributing to the problem or enabling the problem. So that is what we recommend for families. And also just spiritual life, the importance of having a sense of purpose. A formal religious support system, if that person has been part of a church or synagogue but has really gotten away from it, then it's really important for us to look to find ways for them to reconnect. And it doesn't have to be religious. It may just be more of a spiritual connection that can really help that person cope with some of the challenges that they're facing in recovery. Structure and purpose is very important. particularly for people who are retired. I mean, most people that you find have this sense of really wanting to have a sense of purpose, and people with a sense of purpose have better self-esteem, and people with better self-esteem have more success in their recovery. So finding ways for people to not only get the counseling that they need, but also the socialization, maybe volunteer work, or even participation in more of the community activities in their assisted living or nursing home. Some of the statistics that we saw in the National Survey of Substance Abuse Treatment, we saw that the majority of substance abuse treatment facilities use some kind of substance abuse counseling that is shorter term and involves some supportive therapy techniques. Encourage a person to kind of tell their story using expressive techniques and develop some relationships. Prevention approach, something that got very popular in the 90s, is more of a cognitive behavioral therapy approach. And if you're familiar with cognitive behavioral therapy, probably the Becks are most well and really devise most of the cognitive behavioral strategies that we use. But to simplify, the idea that if you change the way you think, you'll change your mood. And you can use the cognitive behavioral health strategies for reviews. It's really looking closely at really poor behavioral patterns, pattern behavior. People can really learn to identify new behavioral patterns that are more effective and healthier. So the relapse prevention method really looks at sustained abstinence and learning ways to avoid triggers, recidivism, or restarting. Behavioral therapy, knowing that patterns of thinking and reacting can be very negative, learning new ways or more positive ways to change your thought process, to change your mood, as well as to change your pattern of behavior. In this approach, people have to be very active, and often there's very clear homework expectations so that that person can demonstrate that they're committed to the process and can change. Briefly on the 12-step programs, the idea that early recovery from alcohol abuse and other drugs, there's NA for Narcotics Anonymous, the idea that 12 steps to really make significant changes in one's behavior. And in the past, 12-step programs, I think, really with the mental health movement and of antidepressants and other medications to help people with their mood and the understanding that there may be a comorbid substance abuse related problem, but also there may be some underlying mental health problems like bipolar disorder or depression or anxiety. I think over 12-step programs have really better acknowledged and accepted that a person may be a dual diagnosis and need help in both areas. Voting has gotten a lot more press over the last maybe for 10 years, and it's really based on the assumption that if someone isn't motivated for their own treatment, it's not going to be effective. So not a focus primarily on telling people what they do to be able to change their behavior, but really finding out what they are willing to do in to change their behavior. Use tools. And Nurse mentioned that she put a copy of the MAST, I think the geriatric short version, on the University of Iowa website. You may want to check that out. As well as the CHARM and the CAGE are commonly used tools, tools that you can use or be thinking about to screen substance abuse-related problems in the older adult population. The CHARM is one that is used, again, these are screen tools, so they're diagnostic in nature, but they give you a sense of some of the symptoms that the person may be having and help to ask the right questions. The CHARM is one that's been used for a very long time, the idea that have you ever cut down or quit drinking? How do you use your alcohol? Anyone else ever been concerned about your alcohol or, the amount of pain medications that you take? Do you ever drink more than you intended to? And that is used in primary practice with physicians, a nurse, a cage. Have you ever felt you should cut down on your drinking? Are other people irritated or annoyed or criticizing your drinking? Do you ever feel bad or guilty about your drinking the next day? Do you drink to kind of, get yourself up or get yourself going in the morning? Last few minutes before we take our questions and answers, but Maria asked me to come up with a vignette that might apply to your situation. This is taken from a real situation from a skilled nursing center. So, get that maybe you've had a new admission to your skilled unit. You have late 69-year-old female. She is not coming to your center for long-term care, but maybe because she's had a hip fracture. She's coming for skilled nursing to rehabilitate. She has a history of osteoarthritis, fibromyalgia, anxiety, and depression. Enough, as they often do, are looking to our social worker to help them because this particular resident is very needy, very demanding, and very medication-seeking. Is constantly recall light, insisting on additional pain medication, telling you that she feels anxious and she really needs some relief. And the staff are just not doing a good enough job about meeting her needs. Handle a resident like this. Residents who tend to be very demanding and needy can be very difficult to deal with. The personality dynamic is one that is very off-putting. There's a fine balance, of course, because we are taking care of people. We want to do a good job. We want to provide good customer service. But on the other hand, some of these demands are unrealistic. And so how do we balance the idea of really meeting this woman's needs, but setting limits on medication-seeking behavior? So it may be that she is medication-seeking. It may be that even she's prescribed, for example, 2 anti-anxiety pills per day. It may be that when she's at home, she's taking a lot more than that. So how do you assess her needs? How do you balance with the nursing limitations? And what kinds of steps might you take to assist? These are the situations that get very tricky because we have someone who is alert and oriented and very demanding. We're very respectful, but on the other hand, we need to set some appropriate limits. So what be going on with her? Well, she does have a history, you read from her chart and from her list of diagnoses, of depression and anxiety. And things I've seen over the last 10 years in health is that we're seeing physicians do a better job of addressing depression and anxiety with antidepressants and relying so heavily on anti-anxiety agents like Xanax or Ativan. What happens with those agents? Ativan, you mentioned, are habit-forming, but also their side effects can be dangerous for older people. So 2 common side effects for those medications might be falls as well as being cholinergic. So it makes that person look fuzzier. It impairs their thinking. So think of yourself. Think about if you weren't feeling well and you took a couple of Tylenol PM, what happens? You're not thinking as clearly. You feel a little bit drugged. You go to sleep, you wake up, and you feel a little hungover. The same kind of thing we see with anti-anxiety agents, but they're, of course, much stronger. So we're seeing a lot of physicians that are hopefully moving towards prescribing an antidepressant that has also a calming effect because they're longer acting, they're forming, and less of those side effects that we mentioned. We've got someone here who has a history. We read about depression and anxiety, but also a history of pain. So here we've got some red flags about, someone who's got a long history of pain. There have been a development of dependence on these pain medications. And the more medications are taken, the more the person is going to need in order to get the same kind of relief. You help. And which might you use? How would you manage her behavior? Or transfer her to another facility? We want to take a closer look at the potential idea that she has a substance abuse or dependence reliance on some of these opiates. Situation where we want to use really more of a multidisciplinary approach, talking with the person's physician, nurse practitioner, some of the nurses. And it's a good case to request an order for a behavioral health consultation. And if possible, to be able to get a psychiatrist or psychiatric nurse practitioner as well as someone who may be able to provide the counseling. And we've noticed in some of the changes in mental health care over the years, we really are much more specialized, and psychiatrists have really moved away from doing counseling and psychotherapy. They really focus more on the medication management piece. Address these concerns directly with the resident in a respectful way. There is family or there are friends who are involved. It would be good to involve them to increase support for that person. I think we do have to develop a clear limit-setting plan with the treatment team, sometimes posting a schedule of medications when they're given so that you can keep redirecting that person back to that schedule. Encourage the resident to not ruminate or not obsess about her medications by trying to encourage that person strongly to get out of her room and to get into activities, to get into the therapy. She can't her, so we're trying to get her the therapy she needs to become more independent. We want to demonstrate some empathy. We also want to be pretty directive in setting some appropriate boundaries on her demands related to medication. These are when the physician has prescribed the medications, and so we really have to stick with this schedule. What we can do as a healthcare professional, as a social worker, some brief intervention. By helping people identify the problem, follow through, and encourage them to have an evaluation. Discuss what the person thinks are the pros and cons of continuing that substance abuse. And then making a referral, whether the person really needs some detoxification in an inpatient hospital program, an outpatient treatment program if they're leaving your facility, or if you're fortunate to have some in-house program or counselors that will come into the facility. It's often difficult to accomplish, but it can be incredibly invaluable. But our own boundaries, accepting that you may not have success in getting that resident to acknowledge the problem right now. That there is a lot of denial, that there is recidivism in addiction. But know that the small steps you're taking are planting seeds. Increase the likelihood that that resident will get help now or even in the future. So about, looks like 12 minutes left, so I'm happy to entertain any questions that arise.
That was wonderful. Thank you for sharing. You're clearly benefiting our audience from your years of experience and your insight and your really practical interactions with older adults dealing with substance issues. So thank you for sharing that. If anybody has any questions or comments, please go ahead and put them in the chat box or put them in the Q&A. And I'm looking at Lee's name, and I don't see that he has signed in with his name, so he might be one of the anonymous call-in persons, and I'm not sure which one it is, so I won't be able to turn to him for a question unless he'd like to put it in the chat box. Mentioned happy hours at nursing homes. I'm just wondering, do you have a place for that, or if it's think it's too risky, or do you think it's appropriate because most people don't have use problems? I mean, how would you
suggest? That's a really difficult challenge, I think. And I don't see it so much in nursing homes, but I do see it quite a bit in other levels of care, like independent living, assisted living centers. And you're right, it's a fine balance. I mean, that may be something that someone has enjoyed throughout their life, and professionals do that. Many of the people we interact with might enjoy a glass of wine or beer. So how do we set that limit? And so some facilities have really kind of gone on the minimum and really kind of included happy hours and find that if people want or choose to drink on their own, they're welcome to do that. Other facilities have taken kind of a happy medium whereby they will provide one drink or try to limit it in some capacity. But I think these are, very difficult challenges of balance, of giving people the recreation, pleasure, the enjoyment, the things they like to do, while also balancing the risks. And not just with substance abuse, but also with the idea that if you stay, particularly in long-term care, because that's where the most ill people are, they're at the highest level of care in the long-term care chain. They're also taking so many other medications that interacting or missing those medications can be quite dangerous. And if you have someone who's already taking one of those narcotics that we talked about, one of the anti-anxiety agents or pain medications, those medications can actually quadruple the effect they're taking all. So you have to be kind of careful about kinds of things.
Yes.
But, and so we also have to, be mindful of that. So it's a fine balance.
I don't see any questions that have come in. I don't see things in the chat box.
Okay, well, I know you had asked me a question kind of offline about what do you do if you feel like one of your colleagues is abusing a substance, and how would you handle that? And, I think that if you have a relationship with that person, you might want to mention that you're concerned that there's a problem. But more often than not, what should happen is that's when a supervisor should be involved. And really the best case scenario is to acknowledge that there's a problem going on. There's a disease, there's an illness like any other, and encouraging and making resources available to that person some help. And then refuse to get help, and we have situations where people might be intoxicated or on drugs while they're at work, then of course you would follow your policy and procedure in limiting that person or putting them on suspension or whatever the procedure is. So encourage people to get help if we can.
Okay. All right. Be the first thing to let somebody know that you're noticing that they may be being affected by alcohol or substance use, and encouraging them to get some help. And then also, if this kind of behavior is taking place at the work site, then to contact the supervisor and let the supervisor know what you suspect. You might not know for sure. Some people may be hesitant to because they're not sure, and they don't want to get the person in trouble, and they don't want to hurt their relationship with their colleagues. So,
to handle that, I think. Yeah, I think the best way to handle that is to just focus on the facts. So you don't have to decide whether this person has a substance abuse problem. If you're going to the supervisor, you might be saying things like, I'm really worried about Joy. She nurse's station yesterday and she fell asleep. She showed up late for work yesterday. These are the concerns. This is what I'm seeing. This is the factual information.
You wouldn't have to come up to the conclusion. That would be for somebody else to come up with after they've investigated. But if you're noticing things that might be part of a pattern, then it's appropriate and important that you notify the supervisor and just let that person know.
Absolutely.
All right. Lori, thank you so much. This was really a very thorough and very informative presentation, and it was also interesting to hear about your practice experience, and I was really glad that you wove that in throughout your presentation. So thank you so much.
Well, thank you. It was really pleasurable. I enjoyed presenting the topic, and I hope everyone feels that they got a lot more information on the topic.
All righty. Then an evaluation form that people will be invited to complete they conclude this webinar. And also, if you have any additional questions, don't hesitate to put them out on the listserv, and that way everybody gets to see the question and everybody gets to see the answer. So thank you, everybody, for being with us today, and thank you especially, Lori, for an absolutely excellent presentation. Bye-bye.
Absolutely. Bye-bye.
Okay.